recording. Okay, you're on, Joe.
Ready?
Yep, let's go.
Okay, here we go. So, as you know, Dan asked me late yesterday afternoon to kind of fill in and find something interesting to present. So, here we go. This is actually, here we go. So, we were asked to see this 30-year-old female who had newly diagnosed diffuse large B-cell lymphoma. The diagnosis was semi-elusive. She had 7 weeks of temperature spikes, night sweats, and overall generalized fatigue, and a pretty significant decrease in her overall performance status. She relates having nightly temperature spikes up to 107 degrees that occurred almost like clockwork between 10 and 11 o'clock every night with drenching sweats. She was hospitalized 3 separate times with million-dollar workups with every test, almost every test imaginable to man, with no diagnosis. And finally, which was kind of an enigma to me, because she had a pancytopenia, somebody did a bone marrow aspirate, and she had findings that were consistent with B-cell lymphoma, that ultimately with flow and lymph node biopsy, the diagnosis was confirmed. So that's the starting point. So why was Cardio-Oncology asked to see her? Well, she was born with a hypoplastic left heart. You can see the initial anatomic abnormalities on the slide. And then she had a long series of surgical procedures that are alphabetically listed, starting with a Norwood procedure by Norwood, and that was the A procedure in July of 1986. And then 6 months later was found to have...
Hello, Joe. I just see the title slide. I don't see any other slides other than the title slide.
Ooh.
Hi guys, so, it's Susan calling in.
Yes, so
hi Susan.
I am advancing them on my screen.
I only see the title slide as well.
So you got to click on it.
All right, so I'm not sure what do I have to do something different? Let me see this.
Are you showing your screen?
Okay, how
there
was
you
that?
Go. We got it. Got it.
I did.
Yep.
Okay, so that's the story. FUO for 7 weeks, 3 hospitalizations, and ultimately diagnosed with diffuse large B-cell lymphoma. Okay. So now they don't advance. Hang on. Here we go. So we were asked to see her because she was born with a hypoplastic left heart. The anatomic abnormalities listed on the slide: mitral stenosis, aortic stenosis, SVC to the coronary sinus, left aortic arch with an aberrant right subclavian. So she had her first surgery in July of 1986 by Norwood, who did a Norwood procedure, and then because of perceived aortic, actually perceived co-arc, she was recast and then had surgical repair of the co-arc. And then
could you summarize for those of us who are not intimately aware of what a Norwood procedure is, exactly what that might be?
All right, I'll get to it in a second because it gets revised, and that's the most important piece of it. She then had persistent obstruction, and then Norwood did a non-fenestrated Fontan. So what they did was they placed a pulmonary homograph over the coronary sinus to the left SVT that basically has the flow from the SVC goes to the coronary sinus and then into the Fontan baffle, so that arterial blood can reach the systemic, can be distributed systemically. And then revised the central shunt, the pulmonary arteries, and reconstructed the arch. So basically single right ventricle that supplies blood to the pulmonary circulation and the arterial circulation. And then she had recurrent pericardial effusions and had a window, and then was cathed multiple times in the interim years with basically a functioning right heart with no obstruction and a patent pulmonary artery homograph.
So she had a 20-year period without major issues.
Yeah, you're right. She went from, from her initial surgery in '86, and then the revision basically almost a little less than a year later to some 87, 97, 207, 30 years. I mean, it's coming up on 2 weeks, it'll be 30 years, which is kind of remarkable. And at the point prior to fevers, I mean, at Christmas time last year, she was pretty functional. I mean, exercising to a limited degree, but doing ADLs and functioning as a regular person. So kind of amazing. And she'd been cathed multiple times. It's probably not worth our time to go through all of it, other than the fact that access has been an issue since our IJ is included, and so access issues.
Yeah, well, so her left subclavian can't possibly be normal since.
Right. No, and right. So
she's got basically no access anywhere.
Right.
That would be.
So she was last cathed at CHOP in March of 15. They got in through the right femoral artery and a left jugular vein, and you can see the SATs and her RV pressure pretty decent with only a little bit of TR and the Fontan circuit patent without much difficulty. So that's the cardiac status. She also had a cardiac MRI in 2000, and actually the last one was in 2012, not 2007, but 56 of the flow went to the right PA and 44 to the left, which is actually a pretty good repair. And you can see no right superior vena cava and left SVC, which was in the op note is validated by the cardiac MRI. Okay, so that's not the whole story. So because of lots of transfusions, she has chronic hep C, and at least by ultrasound, the pulmonary arteries are kind of plump, and it's possible that she has some pulmonary hypertension. Like most people who have Fontan procedures, they have protein losing and neuropathy. She's also had a problem with endometriosis and had a hysterectomy 3.5 years ago. On top of that, she has cerebral palsy and has had problems through her youth and adolescence with recurrent seizures. Unfortunately, no seizures recently. And fairly significant restrictive lung disease and requires supplemental oxygen to sleep. Only medications are aspirin every other day to keep as antiplatelet therapy to keep the Fontaine baffle open, and PRN Lasix when she develops edema. Family history, other than her father died from metastatic colon cancer, otherwise unremarkable, non-smoker, no alcohol, no recreational drugs, and currently is wheelchair bound because of her recent illness. So her exam is not that remarkable from a cardiac standpoint. She's small in stature, not overweight, blood pressure 90 over 60. When we saw her, pulse was in the 90s. Neck vein distension up to the lower part of her jaw. Single first and second heart sounds, a little flow murmur that was also not very dramatic. Liver palpable below the costal margin, and you could feel on deep inspiration, you can feel the spleen tip. And she was a little bit fluid overloaded and had edema to the mid-calf. She's had, as I said, $1 million worth of blood tests, but things that are pertinent for us are that her hemoglobin was 12.6, weight count 2100 with a normal differential, and thrombocytopenia with a platelet count of 33,000, and an albumin from the protein losing enteropathy of 1.4 that probably contributes a little bit to some of her edema. Creatinine of 0.47 is, if you body indexed it, is probably still normal with a GFR that's more than 60. And chronic, at least after we started seeing her, the 3.1 potassium was probably hyperkalemia for what her track record has been in the last couple of weeks. Okay, so I apologize. Interestingly, nobody here repeated her echo. It was done, as you can see, in mid-February at CHOP, and I don't have access to any images, but I will read what I basically cut and pasted. So the IVC normal and collapses. The Fontaine baffle looks okay. I mean, basically everybody can read it. It's easier for you to read it and faster than for me to read it. But nothing very dramatic. That her RV basically looks okay. By report, looks okay, and
so, I mean, as far as her, existing cardiac status is concerned, probably fairly stable for her. But so they gave her CHOP starting in February?
No. This was, no. Sorry about that. CHOP is Children's Hospital of Philadelphia. This is at Children's Hospital, not chemotherapy.
Okay.
Okay. Sorry about that.
Yeah, I was like, wow.
Man. No. So we're not up to treatment yet. So this was done at CHOP, and then she ended up here because nobody made a diagnosis there, and they sent her home, and because she wasn't thriving, they wanted to come back, and there were no beds. So because we have an adult congenital heart service here, she got admitted here to the CCU here, and in the CCU, the cardiology attending said, I think we should do a bone marrow biopsy because she has these fevers and pancytopenia, and actually the general cardiologist, who actually is the head of medicine, Mike Parmasek, was on service and made the diagnosis of B-cell lymphoma, which is, I thought, like kind of amazing. So anyhow, nothing that dramatic in the echo. Her ECG is not surprising for what her anatomy is, with right axis and probably has RVH and
extreme right axis and RVH.
Yeah.
Surprised that she had sinus rhythm.
Yeah,
She's
it is pretty amazing, isn't it?
Yes. Surprising, and up to this point she stayed in sinus rhythm, actually, and that was clearly going to be an issue. And this is a little off axis, but you can see that her chest x-ray is not that dramatic. I don't think I can bring the whole thing, but if you look at the side tones, I mean, it may be a little plump, and you can see some sternal virus, but even trachea's deviated a little bit, and but it doesn't. I mean, it's not that.
So she hasn't had any procedure on her chest for 20 years.
30.
Wow.
30 years. And okay, so here are the issues. That's the setting for us to for discussion. So maybe let me go back and say, as a group, let me hear what people would be concerned about if you were asked to see her from prior to getting chemotherapy that she has to get. So I'll open it up now to the group for a bunch of comments.
Yeah, I mean, I just think, she has so many problems and such a complex history that, you'd have to, first question out of the box is, how aggressive are you going to be in terms of treatment? And then if you decide that you're going to be aggressive and you're going to treat her with something, then, I would imagine that the lymphoma doctors of the world would say that they want to use some anthracycline-based treatment.
Okay, I'll as you make comments, I'll make comments. So, yes, I mean, I think the first question is, are you going for curative intent? Is there curative intent here? And because functionally she has been, fairly decent, the initial thought was to try to give her curative intent chemotherapy. Okay.
Joe, can I ask, did you tell us what stage she was?
Say it again?
Did you say what stage of lymphoma she had? Was it stage 2, or I assume it's not stage 4?
So it's made, yeah, so it's probably 4. She has, I didn't give those details, but she has bone marrow involvement and diffused and splenomegaly, and which may be not lymphoma, but do the other stuff. But has on PET CT, she has above and below the diaphragm stuff that lights up with high SUVs.
Okay.
So this is Vinay Tohi, and I'm very interested in this case, and thank you for presenting this very interesting case, very complex. I guess I always ask myself, what is the most proximal mechanism of her mortality? Is it her nutritional state, or hep C, liver disease, congenital heart disease, or is it her lymphoma? And, in her case, I think it's, if I was looking at her, I think her nutritional state really speaks towards a severe chronic, this PLE has been a severe chronic issue with her, and I would venture to guess that while she's ambulatory, she's sort of, as many young folks are, with congenital heart disease, right on the cusp of doing very poorly. So any other insult may shorten her life without curing her lymphoma. And I would advocate a palliative approach to this this case, despite her youth and perception of youth, in fact.
Vinay, that's Really well said. I would agree with that. I think, you know, she's basically wheelchair bound and has these other major conditions that have had a substantial impact, number one. But the other is that, you know, with an albumin at 1.4 right now, you know, I mean, she is in that, just that alone is such a poor prognostic sign that, you know, I don't know.
And
I mean,
can I say, I'm not a hematologist oncologist, but you know, when we look at these people with comorbidities and look at treating them, one of the strongest predictors of how they tolerate their treatment is their performance status. So often, you know, I'll hear residents say, well, they looked good, and then we gave them chemo, and then they become very bad. So, you know, my concern is, again, I agree, if you approached her with aggressive chemo, that because of so many underlying comorbidities, poor nutritional status, poor, you know, relatively not great performance status, these are all markers for poor tolerability of aggressive chemotherapy as well, or high complication rate from chemotherapy. So those are the other things you have to look at despite her age, is the risk of significant toxicity from the chemo. You know, fibroneutropenia, sepsis, and all those things. I mean, her platelet count is low, her albumin is low. It's going to be a challenge to give her, you know, aggressive chemo. So I think, you know, again, I think there are potentially options that to give her something without maybe giving her aggressive treatment.
Yeah, I guess you could argue, you know, I mean, the anthracycline piece aside, you know, I don't know how well tolerated rice chemo is in somebody who has a platelet count of 33, but, you know, that could be an option to do something. But, you know, I really think that this would be a situation where you might consider calling off the dogs.
Yeah, well, there are.
All right, so
Yeah,
all right, keep going.
Just a comment. If they are considering to use the anthracyclines, we need to consider the use of cardioprotection, of course, the dexrazoxane. In this case, I don't know if, we can't.
Yeah, I mean,
stop the talk. Yes, of course.
That's a good point, but I would also add that, you know, one of the problems with desoxane is that it worsens thrombocytopenia.
That's right.
And so I think that, you know, it would be really difficult to do that. But anyway, I'm not an oncologist, so I don't know the answers to those things.
Well, I mean, I think it's good to have the academic discussion of anthracycline versus no anthracycline. But as I think what's coming up, as we've already alluded to, is, you know, chemo versus no chemo. Or if you go ahead with chemo, maybe a much more milder form of chemo, because I think if you were to give this woman, you know, the regular CHOP plus or minus rituximab, I mean, I think it would be very challenging to do. So, you know, I think that's the discussion. So there's, you know, we can say anthracycline, no anthracycline in terms of her heart and her cardiovascular morbidity, but overall, I mean, with all these things going on, you know, and her Hep C as well, I mean, what are you going to do to her Hep C when you start giving her chemo? I mean, is that going to flare up her Hep C? I mean, and her albumin is really low. I mean, it's just, everything is red. There's red flags everywhere here for chemotherapy. That's all I'm saying.
Okay, so here's what happened. Her mother, who was dug in and was absolutely adamant and unyielding that she should be treated to try to cure this.
So can I just make one comment?
Yes.
I think, again, this is not an uncommon expectation of patients and families who are survivors of complex congenital heart disease. If you go back and read the historic information in literature, what you find is that people have been telling this mother and this child since the day they were born that they're going to die in a year, in 2 years, in 3 years. And so this lady, her family, her child, has survived this entire time. And so it's not surprising that they would push very, very hard.
Yes. So our role as cardio-oncologists, what is our role here in putting up roadblocks? I want to hear what other people have to say. Yeah, they didn't ask us. They didn't ask me to say, should we give her chemotherapy? They said if we decide to give her chemotherapy, how will her heart react to it?
Poorly.
Yeah.
So I would say, to just, if that's the question that you're asked, then you would say, or at least what I would suggest saying is, we don't feel that this is, it's like if you evaluate somebody for surgery or an LVAD or any sort of major cardiology treatment, and that that the outcome is, less than 50% likely that you're going to have a successful outcome, then you don't offer it. I mean, you don't say, well, I'm going to transplant this patient so that their heart function is better, or I'm not going to put an LVAD in, for example, because, because of all the prognostic features that have been pointed out. She's wheelchair bound, platelet count's low, albumin's in the tank. There's no treatment that you would offer that has a greater than 50% likelihood of being successful. And so I would lump chemotherapy in that category as well. But, that's not for me as a consultant. It's not for me to say. I'm not the one that's going to make the call on chemo. So my first answer would be, I don't think this is going to be successful, and you're only going to hasten her demise, and it'll be very unpleasant. So that's that. But if you decide to do chemo, if that's what you ultimately decide, I would say I can't see how desoxyzine could be used with that low platelet count, and I don't think that anthracycline-based treatment has any hope of being tolerated. And then I would say, good luck. About all you could do is follow BNP and try to keep a close eye on her volume status, but that's going to be super hard to do. And she's, people with essentially a Fontan, they're very volume sensitive, and so that's going to be just an unbelievable challenge. I don't even know what to say about that, because I don't know how you would follow it.
Yeah, so actually her BNP was like 2100, right? So not surprising. So, I mean, we basically said what you said, Dan, that the risks are unbelievably high, that she's already starting with pancytopenia, that the volume issue is going to be like dramatic, and it's hard to give R-CHOP with, I mean, you can reduce the volume and concentrate stuff, but you can't get away without a lot of volume. That somebody mentioned dexrazoxane, that probably A, that's not really indicated, would be that also adds volume to the whole business, and as you said, that the Fontans are exquisitely volume sensitive. That's probably like a major hurdle in the whole business, and then access becomes an issue too. I mean, she doesn't have no access. Right, like there is no venous. There's no way to get to her central venous system. It's not possible. Well, so
well,
go ahead.
Hey, this is Suparna here, the Cardio-Onc fellow at Penn. I've been taking care of her. So we did find an access modality trying to mitigate the risk of thrombus formation from having a central venous, or a PIC essentially, or catheter proximal to the Fontan. versus balancing the need for chemotherapy delivery. So we did an early terminated axillary pick essentially for her, trying to balance both the needs for giving infusional chemotherapy and also trying to mitigate risk, because patients, as you guys probably know, with PICs Fontan patients with PIC have an increased thrombosis, and that there was concern that thrombus propagation, or even if there was a thrombus that formed at the end of the PIC tip, that the propagation would essentially compromise the Fontan circuit. So there's early termination, and that way the chemo could still get delivered.
Yeah, well, that's quite a extraordinary effort to, do your best, basically. The other thing I would say is, I don't know what her uric acid level is, but, especially a person with Fontan and protein-losing enteropathy has probably got a very high uric acid. And then
I think it was actually pretty low. It was normal when she came in, like 3.4, and I think yesterday she got labs and it was 2.2, so not too bad.
Good.
Yeah, so tumor lysis syndrome would be equivalent to ventricular fibrillation.
Yeah. So.
Yeah. So anyhow, they ultimately, after lots and lots of discussion and back and forth about what to do and what not to do, they gave her a first dose of split chop. Basically, is the half of they just divide the dose in half, and so she got a half dose of chop and tolerated it and went home. So anyhow, the story is not over, because
it is not.
because it actually gets worse, and Suparna might not even know this part of the story yet.
I got a call yesterday in clinic.
But they basically her fish now shows that she has she's MYC positive, which is now the garden variety diffuse large B-cell lymphoma is now a pretty aggressive B-cell lymphoma. And
what is MYC?
MYC is a MYC. It's
some bad marker for lymphoma.
Yeah, it's a marker. There are lymphomas these days. There are probably 30 or 40 different kinds of lymphomas, depending on all of the
So it's like
the markers. So MYC is a negative prognostic marker. So when people talk about double hit, MYC is one of the ones that's one half of the double hit story. So anyhow, she's got an aggressive lymphoma that probably is not going to respond to CHOP, and there was some discussion with the oncologist yesterday about hyper-CVAD, which is like the worst idea that anybody could ever come up with. And I think that she really needs a discussion with her mother that this needs palliation and not aggressive treatment. That and I don't know about you guys, but we are, for some reason, we are more often in the role of being the informers of bad outcomes, and to have frank discussions with patients about their prognosis. And the oncologists here are, for the most part, pretty bad about that. I mean, they really, if I was going to mark our cancer center with something, it's that they are really late in throwing in the towel.
Yeah.
So,
Well,
so can I comment?
But we have, I don't know if it's your experience, but I mean, I did like once a month or twice a month, we have to sit down with an outpatient that we're seeing who we may have seen, you know, for some short period of time, and to have a frank discussion about what their real prognosis is, and not based just on what their cardiac prognosis is.
Can
You
I
know,
make a
Dan, are
comment?
you in that situation? Yes, Susan?
So I'll address the 2 points. So just to let people, so MYC is an oncogene, and I didn't realize they were using it for prognosis now, but so overexpression of that oncogene is associated, like you said, with a more aggressive lymphoma, and so this makes it, you know, to sort of say it confers a worse prognosis even if they are getting chopped. So that's number one. So, you know, to say that you can take a person like this and give them even more aggressive chemotherapy, you can't even give her the regular CHOP, let alone more aggressive chemotherapy, because of all her underlying comorbidities. The second part, in terms of, you know, conferring the bad prognosis and bad news, I think that is very dependent on the oncologist. I mean, I think what I'm seeing more and more of as people, you know, as people read the papers and the magazines, they come to us sometimes with the expectation that no matter what, we can do anything. And I think, you know, the hardest thing is to try and tell someone, and it sounds like this mother, you know, has been really pushing that the worst thing to do is to give this woman aggressive chemo because you're going to make her incredibly ill and you're not going to cure her of her disease. And so that's a hard conversation to have. And so the easiest thing for oncologists to do is to treat somebody. That is easy. I can write chemo, no problem. The hardest thing to do is to sit down and have that conversation and to say that, you know, treatment is not only is it not going to cure you of this disease, it's going to actually make you worse. And not everyone is comfortable having those discussions. And I've actually been fired as an oncologist in the past for having those discussions. But I think you have to be real with these people. It's not fair to sort of say, well, sure, we'll give you this chemo, knowing that it's going to make them incredibly sick and that it's not going to help their disease. So I think, you know, sometimes the truth is hard, but I don't think that discussion should be left to the cardiologist. I think that the cardiologist can say, you know, that they're not going to tolerate this treatment from a cardiovascular standpoint, but it's up to it's really the oncologist that has to say, you know, this treatment is really not going to be helpful. And if they want to get a second opinion, that's fine. I mean, maybe that second opinion will solidify that. But I think I feel really strongly that the oncologist's role is to have that difficult discussion. But it is difficult, and sometimes people shy away from that.
Well, in defense of you know, oncologists in general, I would say that, you know, I'm sure that they have lots of difficult discussions along that line. But let's give another example, and this would happen probably daily or at least every other day here, where you have advanced heart failure therapy as an option. So you have, you know, people talking about VADs or transplant every single day on all these super sick people. And so, for example, I had an outpatient of mine who came in, had some fevers or whatever, and you know, cratered, basically. He had severe heart failure to begin with, and then he had some sort of sepsis-like syndrome on top of that. Gets in the ICU, and, you know, he's illiterate, and he had no resources at home. You know, I mean, he had like, you know, $50 to his name. And basically, you know, because he was a young man and we do VADs here all the time, you know, he gets in the VAD vortex and ends up with a VAD. And, you know, he's been in the ICU for 120 days now. So, you know, cardiology, and in particular heart failure, didn't have that conversation, which was, you know, enough is enough. We are not going to be able to, you know, straighten this out. You know, God's going to need to intervene here. And we do not need to be putting a mechanical device in this person. And, you know, so I think that cardiology are certainly susceptible to not having these difficult conversations. And so, you know, I think that it's unfortunate, but it does happen. Happens a lot.
Yes.
So, Joe, can I ask what is happening now with this patient? What's the plan now?
Could
So
I
I
ask
talked to.
Could I ask
Yeah.
just a dumb cardiology question? And that is,
Yes.
what was the urgency to give chemotherapy if this lady has had this presumed illness for 6 months? I mean,
No,
in other words,
Yes,
would you
7
have
weeks.
waited for all of the FISH analysis and all of the other stuff to basically come back before you sit down and say, okay, realistically, your chances of survival with chemotherapy is 5% and your chances of survival without it is 5%, and you know, let's just be realistic on quality of life based on the genetic markers, et cetera. And I agree with the oncologist to get a second opinion and have the discussion.
I don't think there was any rush. Well, I don't know. You know, I agree.
So,
It's
I
been
think-
there for 6 months.
I think there's a little bit more background I got in talking with the adult congenital folks. So she'd been getting a workup at the Children's Hospital for a few weeks, and I think the mother was getting progressively more frustrated with the lack of diagnosis, and there was some a push for answers and a push for essentially a fix or the beginning of a fix, and there was, I think, a kind of a litigious tone to some of these things. Plus, I think she had been getting worked up for these non-specific symptoms for a period of time. So I think when we found a potential answer, people were finally like, okay, well, we have something to work on. And I think that was part of the motivation to keep going.
So here again, this is always difficult, right? And I can understand that, and we run into this, you know, all the time. But I think it's trying to find that balance between, and you know, what is the best option for that patient, and balancing it with what's, you know, the frustration of it taking a while to diagnose things. But I think the hardest thing again is, you know, again, now we're in a situation where she's had a bit of chemo, she has this really bad prognosis, diffuse, you know, B-cell lymphoma, and I would really have reservations about continuing treatment in her. But I don't know what the conversation, if the oncologist has had the conversation yet with the mother and her, but I think there's nothing good in this situation at all.
Yeah, I think that if my assessment is that they, the mother put a lot of pressure on everybody, and that the person who was making decisions yielded to that pressure.
It's hard. It's hard not to. I can tell you, we get it all the time.
No, I think that,
Yeah, as I said,
I mean, our role was we commented on the risks, and then, I mean, we dropped out. I mean, it was not, we answered the questions that they asked us and gave them our opinion, and then we were not included in any, you know, additional decision making.
Yeah, sometimes psychologists
I mean, that's not like,
need
that's
to.
not a cop-out, but that was our role, and we, you know, we did our role. Somebody's
the primary doctor. Somebody has to make those decisions. So not everybody can be, you know, in the final phase of decision making. So
yeah,
I mean,
so the adult congenital people were involved, who were the primary cardiology piece to it. There were several different hemonc attendings who participated in decision making. So.
Yeah,
sometimes
I did talk to the person who saw her yesterday when he told me about the MYC abnormality and the and that planning hyper-CVAD, and I told them that it was not, it was like a really bad idea.
Sometimes for this kind of family, it's very difficult to understand and accept, because the mom may be feeling guilty for all the things that her daughter is passing now. The psychologist must work hard on this case together with the doctors. What do you think about it? To make the things very clear and frank, as everybody is telling until now.
Yeah, I mean, I think, any kind of resources like that to assist with discussion are certainly good. So, but I mean, sometimes it doesn't matter. It doesn't matter how many people you get involved.
No.
Well, I think that it comes down to just because you can doesn't mean you should.
Well, that's why I brought up the example of the VAD in a young man that's dying in the ICU.
Right.
Just because we can do it, for God's sake, we shouldn't. And so, in somewhere along the way, somebody has to just say enough is enough, and
And I think that that's what our jobs are. And again, patients in the U.S. do this a lot more than in Canada. But I always say to someone, if you feel uncomfortable with my recommendation, then go speak to somebody else. And sometimes that does help if they hear it from more than one person, more than one hematologist or oncologist. But I think the worst thing you can do, and I've seen this too, I've walked up to the floor and seen people actively dying as there's chemotherapy infusing into their arm. And that's actually wrong. That's actually very wrong. And that's not why we give chemotherapy. So I think it's our job to tell people that. And, I'm just the same with you guys. You must see people who want a heart transplant, but for whatever reason they don't qualify. So they may want one, but that doesn't mean they can get one, right?
And actually, when we're faced with that situation, which occurs not that uncommonly, we tell them very frankly, we can offer you a second opinion from another center or from another resource. And oftentimes just that discussion opens the door to, yes, I understand we're not eligible.
Yeah, I think that's a fair thing to do, because I think, and because I feel very strongly that the worst thing to do is just to proceed with giving a therapy that's going to make things absolutely worse with no benefit, because to me that's just wrong. And I know there's a lot of pressures from families, and I feel it in the world of breast cancer. Believe me, it's very, very, some people want to be very aggressive, but I think the last thing that we should be is to be pushed into giving a treatment that you don't feel is going to benefit patients. And that's where I think I draw the line. So I agree in this case, just maybe speaking to another hematologist, even a different center, sometimes is enough. Or even just, like you said, having that conversation is enough. Agree.
Can I ask just a question for the community at large? I've been thinking a little bit about the real risk of anthracycline toxicity in her as it pertains to her myocyte function. So she has a morphologic RV that's a functional LV, right? And myocyte white, it should be a mix of RV cells and LV cells. And if they're functioning at primary capacity, then they're working in her EF is 70%. Do we know anything about how anthracyclines affect these different cells preferentially? I've not seen an isolated RV toxicity from anthracycline, but certainly LV toxicity is known. And is her risk mitigated by the potential for having a mixed myocyte?
No, I don't think, there's no myocardial difference between the RV myocardial cell and the LV myocardial cell. They're basically the same cell. It's just, anatomically and the way you develop, your RV is thinner and whatever, but the actual cells are not different. And in this case, her LV never formed her RV
Right.
would be anatomically, you know, thicker or whatever than what it would have been, you know, if she had a normal heart. But she would be at risk for anthracycline toxicity, just like any other cardiac cell would have been. And I would say that she already has RV dilatation, and so she would be at super high risk, just no question. And then of course, you know, the whole volume status is basically impossible in this particular patient. But you know, I just think she would be at super high risk because her RV is already failing. It's beginning to fail, and you know, so this is a situation where, you know, even if everything else was perfect, that this would be a super high risk patient. And I would say if you could avoid anthracycline, that would be the way to go for sure.
Yeah, and just to echo that, I mean, what we know from the LVAD literature is patients that have anthracycline cardiotoxicity are twice as likely to need an RVAD as a typical patient with LV dysfunction from another cause. So they certainly are more likely to have biventricular issues if they have anthracycline cardiotoxicity than a patient with other causes of LV dysfunction.
Yeah, that's totally true. Yeah, good point. So interesting case there, Joe. You just
Very interesting.
It stimulates discussion, which is good. It was the purpose of getting us together. But I think that, I mean, in the whole congenital world, if she had no comorbidity, the risk is still high because of the volume status and because her RV is not completely normal, that she probably, as Dan said, would, with everything else being equal, would still be at a higher risk to develop late anthracycline cardiotoxicity. Although she's already, I'm not sure what late is for her. I mean, she's 30 years out, which is kind of a little bit on the amazing side, right? That she hasn't been transplanted. So,
I mean,
so I just, the thing that's like totally even more bizarre about this case is that there was discussion from the congenital people that said that once they cure her lymphoma, they would consider her for a heart transplant.
wow.
Come on.
wow.
Yeah, so I mean, this is beyond the realm of
Yeah, that is such a ridiculous comment. I can't even address it. I mean, that's crazy.
But I think that not only is it ridiculous, if that was even discussed in the context of care with the patient and her mother, what do you think the mother's going to want to do then?
That's right.
No, that's
what
like, I
will be
mean,
her
I think her mother's expectation is that once this is over, that she's going to get transplanted.
I see. That's
the problem.
That's really irresponsible, I have to say.
I mean, I don't want to be crude, but she is going to get transplanted, but it is not going to be her heart. It's going to be.
I mean, the only place she's going to get transplanted to is in a box.
below ground.
Yeah.
You know, I think the problem is that when you have all these people involved, I mean, the key is that everyone has to be giving the same message. And it's really bad if the patient and, you know, in this case her mother are getting mixed messages. That is really bad. Yeah. So that's where, you know, everyone has to get together and discuss it and discuss what the plan is and then discuss it with the options with the patient and the mother, because otherwise, you know, it creates a lot of problems all around. I mean, that's just not going to work. That's not going to happen. You know, she'll never make it. No way.
Well, she wouldn't even be a transplant candidate. I mean, she has PLE, she's got Hep C, she's got complex congenital. I mean,
she's not a candidate even without
seizure disorder, wheelchair bound. Yeah, I mean, yeah. It's like, that's crazy, man. That word shouldn't have ever even come out of anybody's mouth.
Absolutely.
Agree.
But one of the things, I mean, we have like 2 minutes. I just want to just bring to the forefront is that for those of us who see see the adult survivors of pediatric cancer, that I would say that even into their 20s and 30s, that is more usual than not that they come with a parent. And
Yes, that's true.
And the parents have very different expectations that are sort of developed over decades of chronic care for these now young adults, and are oftentimes the major decision makers in how care gets delivered.
They didn't, you know, in essence, the patient frequently, you know, I wouldn't say 100%, but frequently, more than 50% of the time, didn't get to develop as an adult and make adult decisions. And so that carries through to the survivorship world for sure, just as it does for congenital heart disease. I mean, this is a huge deal. Matter of fact, I just had, like 2 days ago, a big long conversation with a patient and her mother. The patient's 23 years old, but so anyway, you know that technically is she should be making her own adult decisions, but you know it doesn't work that way. So yeah, it's.
I have a couple of 40-year-olds that come with their mother and father. Seriously.
Wow.
Okay, guys, this was fun. I thank Dan for giving me the opportunity to stimulate some discussion.
Absolutely.
Hey, thank you.
All right, thanks everybody.
Thanks everybody.
Thank
we
Thank you.
would like to convey to you that we have a celebration for Dr. Post, who's starting his first cardio-oncology clinic for HCA Healthcare. And so we're pretty excited about that because we wanted entree into HCA for a long time. And so we'd like to ask for some emails to congratulate him. And so we'll put on our screen how you can get in touch with him. And so here's Dr. James Post, and there's his email address and his telephone, and we're basically congratulating him for starting the first HCA Healthcare Cardio-Oncology Clinic. So a note from congratulations from you would be very helpful to encourage him in his endeavor.
Super. Thanks a lot. That's
Thank
great.
you.
Okay.
Thank you so much.
Bye, guys.
Bye.
Okay.
Okay, thanks everyone.
Thank you.
Bye-bye.
Congratulations. A good case.
Goodbye, Sebastian, Serena, Soprana, Susan, Maria, Janine, Germaine, Calvert. Have a great day. Thank you so much for coming to our meeting.
Thanks a lot.
Appreciate
Thank you, Eric.
Yes, thank you, Sebastian.
Thank you.
Thank you,
Dr.
Dr.
Ray.
Harrison.
Thank you.
Thank you so much. We appreciate your coming. Look forward to our next meeting. And a word of congratulations to Dr. James Post.